Actually, maybe what we'll do is have Thage speak about Seal while the others are rolling in, and then hopefully by the end of that, we'll have enough of a mass where we'll go ahead and get Dr. Sandberg started as well. So go ahead, Thage.
Sure, that sounds great. So thank you all for joining today. I really appreciate every one of you, all the time that you guys spent on this. My name is Tej Patel. I am one of the co-directors of the Social Equity Action Lab, also called SEAL. And today we have honestly the pleasure to host Dr. Sandberg today for one of our panels. But I wanted to take some time to explain what the purpose of SEAL was, how it was founded, what we do. So SEAL was founded about a year and a half ago, where Bob and I essentially wanted to find an outlet to translate our research in the academic capacity to actual policy change. Ever since we founded SEAL, we've launched a variety of teams in the fields of global health, healthcare delivery, healthcare decarbonization, surgery, and a variety of other fields. And these teams are working on actually trying to create research, primary research, and then find outlets to actually translate that into policy change. And what I mean by when I say policy change, I mean either working with political candidates to help them on their healthcare campaigns, or doing direct advocacy both on the ground as well as at large, but both state and federal levels. So we have a variety of students. We've collected about 50 to 100 students through our organization who are working on a number of interesting projects. And we are so happy to have them here today to hear Dr. Sandberg's amazing talk. So thank you all for your time. I really appreciate it.
Excellent. And with all of that, I'll briefly introduce Dr. Sandberg, and then we'll go ahead and get started here. So we are honored to be joined by Dr. David Sandberg, who is a nationally recognized pediatric neurosurgeon. He's also served as a professor of neurosurgery at the McGovern Medical School at UD Health Houston, where he also holds the Dr. Marnie Rose Professorship in Pediatric Neurosurgery. He has served as the director of pediatric neurosurgery at the Children's Memorial Hermann Hospital and the Memorial Hermann Mischer Neuroscience Institute. Dr. Sandberg had earned his undergraduate degree at Harvard, his medical degree at Johns Hopkins, and then went through his neurosurgical training both at Cornell as well as at the Children's Hospital of Los Angeles. His research and broader clinical interests have spanned brain tumors, spinal anomalies, hydrocephalus, craniofacial disorders, and vascular malformations. He has been a leader in several trials also aimed at improving treatment for children who have brain tumors. And in addition to all of this work, he is most importantly the author of a wonderful new book entitled Brain and Heart. And it's a moving memoir that shares his own journey through the emotional and ethical challenges of pediatric neurosurgery. Fluent in Spanish, he has also volunteered in other nations such as Haiti, Guatemala, Peru, and Uganda. So with all of that, I'm extremely excited to welcome Dr. David Sandberg.
I'm excited to be here with you guys, and I'm so grateful, Bob and Tej, for the kind introduction and for inviting me to be here. This is kind of a different kind of talk that I hope is particularly useful to students like your group who are interested in medicine. Some of you may be interested in surgical careers or even in neurosurgery. And so I'll share my journey as outlined in this book that I just wrote, and I'm very excited about. So let's see here, I can advance. So first question that many people ask is, why did I write a book? I'm a busy neurosurgeon. I have lots to do. And so outlining the answer in these bullet points. Number one is, as a physician of any sort, we see amazing things actually. And I've accumulated amazing stories over the years, the kind of stories that I've thought to myself, somebody has to hear these stories about patients and about other things that happen in hospitals. They're just amazing. So I would occasionally take notes and write things down in case I got the urge to write things down so I would have something to remember later. In terms of families I deal with the most challenging circumstances for families. The death or disability of children is heartbreaking. I have very difficult conversations with families. There are many books that are written from the patient perspective, what it's like to go through certain illnesses. There are fewer books, if any good ones, that really share what the doctor goes through when he or she goes about his day, and the struggles that we face. And so I've often thought to myself, I choose my words very carefully when I have conversations with families. It would be interesting for families to know what goes through my mind when I'm having these conversations. Most relevant for this audience, I think, is it's really designed for students as well, students at any stage, young students, young residents, to see what a day in my life is like, what the training is like, what actually I have to do, what are the hard things that I have to do, and what are the struggles that I have, because it might convince some of you that this is not for you, whether it be going into medicine or going into a really challenging career like neurosurgery, or it might do the opposite, which I hope it does inspire some to say, wow, this is amazing, and this is something I can do, and this is something maybe I'm meant to do. So a lot of this I'll talk about, and then details are obviously more present in the book, which I hope some of you will choose to read. And then thinking about my legacy, what's going to be there for my children and others who may be interested in my story when I'm long gone. So those are the reasons that I wrote this book. So the target audience, obviously families of children with neurosurgical or other conditions, college students, med students, residents, neurosurgical colleagues, or just anyone interested in great medical stories. And especially my focus is on the doctor-patient relationship from the doctor's perspective. So choosing a title, brain and heart. When we think of neurosurgery, we think of a very exact science, at least I do. We think of the precise functions of the brain, which are incredible and being understood better year after year. We think of the precision associated with neurosurgical procedures, how we can use frameless stereotaxy and robots to target very small areas deep within the brain to perform biopsies or different treatment modalities, insert catheters or electrodes, etc. But surprising to many of you, and certainly surprising to the lay public, is how little of what we do is actually based on science. There are not good clinical trials that outline what to do in every scenario that we face. In fact, there are not good clinical trials or scientific data outlining what we should do in most situations that we face. So it's based on a combination of our training, our instinct, our gut, and kind of our heart. What we would do if this was our family member. Because if you get 5 neurosurgeons in a room about many cases, you would get different opinions. So how do we decide what to do? It's also about heartbreak, because we experience the highs and lows. Heartbreak for the families who experience tragedies, and actually heartbreak for ourselves as well. And I talk a lot about that in the book. So in terms of the subtitle, The Triumphs and Struggles, pediatric neurosurgery in general, and particularly pediatric neurosurgery, is a profession of really deep highs and really deep lows. So the most extreme, saving the life of a child, brings joy that I can hardly even put into words. Losing a child brings pain that I can hardly put into words. And there's a lot of these extremes. Luckily, most of our outcomes are good and most of our endings are happy, but not all of them. So chapter 1, I talk about the lack of precision of our knowledge. Using the example of Garrett, any patient's name I use is with the permission of the patient and or their family. And this is certainly with his permission. Garrett was a teenager who was riding an ATV and the ATV flipped over. He wasn't wearing a helmet, and his CT scan after he arrived at our hospital showed this epidural hematoma. This is chosen because it's a very straightforward case. The obvious thing to do is to remove that blood clot, which is shifting the brain over, and try to save this poor kid's life. The problem is that there was a delay in his transport by helicopter to our hospital, and by the time he arrived, his examination was so close to brain death that I wasn't sure if he was salvageable. And in the book, I go through the decision-making process in great detail of how I decided what to do with this child. And at the end of the day, I wound up taking him to surgery and saving his life. And he actually came to my book event in Houston a couple months ago, And you would never know that he had a brain injury. He wound up going back to high school. He was on the golf team. He graduated high school. He went and works at a nuclear power plant. He's a wonderful kid. And you would never know anything happened to him. And so to his parents, I'm the hero. They lavish our team and me especially with gifts. They come back year after year. I'm like a family member to them. But to me, his case haunts me because when I'm honest, I recommended to his family that we not proceed with surgery. What I told them is that I think his likelihood of progressing to brain death is so high. And if he survives, based upon my vast experience doing this over 2 decades at a busy trauma center, you know, I think he is likely to not be the same kid you have known and loved, to, be fed by tubes, to be bedridden, fully dependent on care, and not the same child you've loved. And I told his parents, his father in particular, that if he were my son, I would not operate. And yet we operated and we saved his life and he's perfect. And it haunts me because I wonder how many other kids have I denied surgery that could have saved their life? And the answer is I don't know. Hopefully none, but there may be some that are out there. In chapter 2, I talk about the road to becoming a pediatric neurosurgeon. Um, I focus somewhat on mentorship, but really I tell a lot of stories of the hardships of training, which I actually loved. I trained in the days before restrictions, and there was a lot of craziness that went on, and a lot of it is detailed in the book. I think you'll find it interesting. It's a little different these days. And I talk about the positives and negatives of the old style versus the newer approaches to training. And I talk a little bit about mentorship. I was lucky to have some extraordinary mentors. Don Long was the chairman of neurosurgery at Johns Hopkins when I was a medical student. And he treated me with kindness. He took me for coffee when I was on the rotation. He seemed to be genuinely interested in me. And I always remembered that when I was a student, when I was the lowest person on the totem pole, the chairman of neurosurgery at an esteemed institution treated me with kindness. And I vowed that I'm going to do the same. And you'll remember that, hopefully, all of you. And as you become big time professionals, surgeons, doctors, whatever you become, hopefully you'll remember what you feel like now when you're the person who's trying to get an internship or a job in the lab or just tagging along on a medical team. I worked in Henry Brem's lab. He's an extraordinary individual, someone who I hope and have always hoped to be like, an extraordinary leader, person, doctor, compassionate human being, um, doing amazing research on brain tumors, and an incredible mentor to thousands of students whose career trajectories he has changed, including my own. Reed Thompson was the chief resident of the neurosurgery service when I rotated on neurosurgery. And he was so good to me as a student, and I had so much fun that I think it's the reason that I became a neurosurgeon. So I'm so grateful to these individuals. And then moving on to my training, Dick Fraser was the chairman for the first 3 years of my program. He said one thing which always stuck with me, which I talk about in the book, which is that patients always look like their scans. In other words, if a patient looks good, but their scan, their CT or MRI looks terrible, you better watch that patient because they're going to deteriorate. And similarly, if a patient looks terrible, but their scan doesn't show big strokes or other major problems in the brain, that patient likely has some hope. And I've taken that pearl with me in my career. Phil Gutin was the chairman of Memorial Sloan Kettering Cancer Center, a big time brain tumor surgeon and researcher. And I've been interested in brain tumor research. So he was a real mentor of mine. Bill Stieg became my chairman for the remainder of my program. And my biggest single influence in my life outside my immediate family was Mark Swadan, who was a pediatric neurosurgeon. When I watched the way he did surgery and the way he interacted with patients and his bedside manner and just his life being a pediatric neurosurgeon, I said to myself, that's what I want to be when I grow up. And that's who I want to be. And I'm still trying to be Mark Swadan. I did my fellowship at Children's Hospital Los Angeles. I had the honor of training under two very esteemed pediatric neurosurgeons. I worked incredibly hard. I was on call every other day and night. I did about 600 surgeries during that year, and I was battle trained and felt ready to go and become a pediatric neurosurgeon when I was done. An extraordinary experience. So after going through my background, in chapter 3 of the book, I talk about telling families the worst news they've ever heard, the worst conversation they've ever heard, helping them process a fatal diagnosis. This family, I used their picture with the permission of the father. Um, and, this is an example of giving bad news, right? So the boy, his name is Gus, has a malignant brain tumor that kept recurring. And he was a patient who enrolled in my research trial, one of my research trials where we're trying to find alternative means of treating these incurable tumors. His mother died a month before um, one of our trials of a sarcoma, and he was the only child. So this poor father lost his wife, and his son had an incurable tumor and eventually died as well. And so I talk about the conversations. Now, I don't include his story in the book, but I talk about conversations like this. Can you imagine talking to this father who just lost his beloved wife a month ago and telling him that the chemotherapy treatments in the brain that you're infusing as a last-ditch effort to save his precious son's life have failed and are not going to work, and he's going to die of his disease? These are the types of conversations we have, and they are so important, and somebody has to do them. You might be, as a student, you might be like, wow, I don't know if I could stomach that. Or you might be like the way I was when I was a student, which is these are really important conversations. And I actually think I can do a good job having those conversations with honesty and compassion. And even though you're giving bad news, it makes a huge difference how it's done. So that's the kind of thing I talk about in this book, how I give specifics on how I have those difficult conversations. Because there may be some training at medical schools currently. I had zero training in my career regarding how to have these conversations. Chapter 4, I talk about the rewards of saving a child's life. Um, I give this example of Marcella, who is the most important patient in my career, who I met as an 8-year-old girl when I was volunteering at a hospital in Honduras during my research time. I took a month and volunteered at the Hospital Escuela, a very poor teaching hospital. And I met this little girl surrounded by children who were dying of treatable diseases. And she had this massive tumor that you can see on the MRI in the suprasellar region of the brain, causing hydrocephalus. And I knew, looking at these imaging studies and hearing her history, that this was a curable tumor called a germinoma. With that had at the time, that's currently treated with radiation and chemotherapy. At the time, it was treated primarily with radiation therapy with a 90% cure rate. And I knew this girl was going to die in Honduras. And I knew that if she were in my hospital in New York when I was a resident, we would save her life with a 90% certainty. So I called my mentor, Mark Swadan, who I mentioned previously, on the phone. I called from a payphone. Have you guys ever seen a payphone? They're before your time. So I called him. I remember where I was standing when I called him from a payphone at the hospital and told him about this girl. And he said, well, let's bring her to New York and save her life. And that we did. We brought her to New York, and it was incredibly hard. Bringing a patient from another country, you got to get the hospital to donate the care, which costs over $100,000. You got to find a place for her to stay. You got to figure out how she's going to be fed and housed and who's going to care for her. It's a massive ordeal getting a visa for her to come to the United States. But that we did. We did an endoscopic biopsy, which proved that it was indeed a germinoma. She was treated with involved field radiation therapy. And as you can see, the top images are before treatment, the bottom images are after treatment, and her tumor completely melted away. And she was disease free for 24 years. And most importantly, her story teaches that, to her mother and to her family, again, I'm the hero and I saved this child's life. There's no question this child would have died without my intervention. And yet I feel as though she and her family did more for me than I did for them. And I say that genuinely. And I say that because, you never know how you're going to get back when you give to someone. In this case, at the time she was supposed to come, was a very busy neurosurgery resident. And there was a charitable organization that had arranged housing for her mother and for her to come to our hospital. That housing fell through the day before they were supposed to arrive. And so I moved in with my girlfriend at the time, Amy, And I gave my apartment to this mother and child, mostly because I had literally nowhere else to put them. Um, I asked my girlfriend to do me one favor because she was a better artist than I was, which is to make a welcome sign to bring to the airport to pick her up and her mom. So we went together to the airport, and that's all I asked. Um, but I would come home late at night from my busy days as a resident and find this little girl on the floor with my girlfriend, who I asked to do nothing except make a welcome sign, and they would be playing. And my girlfriend did not even speak Spanish, and this girl did not speak a word of English. But my girlfriend, Amy, she learned Spanish, and I watched how she was treating this child. And I was like, this has to be the mother of my children. I'm going to marry this woman one day. And that I did. And this is Amy. And this is Marcella and her younger sister, Catherine. And as a wedding gift to ourselves, we brought them up, and they were the flower girls at our wedding because I attributed, our interactions to finalizing my decision to propose to Amy, my wife. And we've been married for many years. Unfortunately, well, she went on to become a medical student. And unfortunately, in the book, this has a happy ending where she's a medical student. She's going to become a pediatrician, showing the absolute beauty of what we do, but also the cruelty of life and what we do. This actually has a tragic ending, which is not in the book. After the book was published about a month ago, Marcella started having shortness of breath, and she went to the hospital in Costa Rica where she was a medical student, and she wound up being diagnosed with a pulmonary embolism. And she was doing well. She was being treated with anticoagulation, which was the appropriate therapy. And a few days later, she just died. And it's absolutely, devastating for her family, obviously, less so, but profoundly also for me as well, because she was like family to me. Um, The next chapter is about surgical complications. If you're going to choose a field like neurosurgery, you need to know that you will be the rule, not the exception. You will have surgical complications, and you have to be able to deal with that emotionally. And it's not easy. This is a child I talk about in the book who has a spinal cord tumor, an intramedullary spinal cord tumor. And I mention him because, as I talk about in the book, he walked into my office. And after surgery, he never walked again, after my surgery that I did. And I'm responsible for that. And I talk about, what happened in the surgery, whether there's anything that could have been done to prevent it. Sometimes there are things that we could have done better or differently. Other times there are not. Other times you're not sure. But I talk about the emotional process for surgeons of when you have complications, which every neurosurgeon and every surgeon really has. They're more profound when it's neurosurgery, when it's the brain or spinal cord, and they're more profound when it's a child. And I talk about the process of going through morbidity and mortality conference and all the mental gymnastics we do when we have surgical complications. The next chapter is a day in my life. I think this will be particularly important for students like you guys who are deciding, is this something that I want to do? Because I think when I was a medical student deciding what to do, and I fell in love with neurosurgery, one of my major questions was, can I do this and be a good husband and father? I grew up in a wonderful family. My parents paid a lot of attention to me. My father was an ophthalmologist, was very present in my life, and he didn't work that many hours. As an ophthalmology, it's a fairly, cush specialty for most, you know, specialists. He was home by 5 or so. We were eating dinner as a family at night, every night. That's not the case for neurosurgery, or for many neurosurgeons anyway. And so this chapter is basically how I manage my family life. These are my kids many years ago. They're now 17 and 14. I just like this picture because I'm in my scrubs coming home, picking up both kids. And the punchline is that it is completely possible to have an absolutely wonderful family life and to be a neurosurgeon. And I'm proud of the fact, I may be one of the few, but I'm proud of the fact that I have been a 50-50 parent, and I mean that throughout my children's lives. I changed as many diapers as my wife did. My wife happens to also be a busy physician. She's an ophthalmologist, but works like a neurosurgeon. And so I talk a lot about, how to juggle family life and work for a busy medical specialist. In the next chapter, I talk about all the preventable things that hurt children, because I see that all the time. There is so much that is beyond our control, and there's so much that is not beyond our control that is preventable. I've seen so many horrible gunshot wounds. I work and live in Texas where there's a lot of guns, and there's a lot of guns that aren't locked up. And I've seen 4-year-olds shoot themselves in the head and die, not knowing that what they're holding was a dangerous weapon, thinking it's a toy. I've seen, I had one memorable situation where a twin shot his brother, had no idea he was doing it. And the brother died. And, that twin has to live with this death that he caused of his twin brother, and devastating for the parents, for the whole family. So I talk about gun safety. I talk about bicycles. You got to wear helmets. Some of you are on the Stanford campus. I was literally just on the Stanford campus, and I would say 95% of Stanford students riding their bicycles do not wear helmets, right? And these are a bunch of smart kids. And I want to shake them and tell them how idiotic it is for them to be riding on campus not wearing their helmets. I've been practicing neurosurgery for over 20 years. I have never seen a serious head injury from a child or adult wearing a helmet. I've seen concussions, I've seen some minor stuff, but I've seen countless deaths and patients who are neurologically devastated because, some car swerves and doesn't see them, hits them on their bike, they fall, they hit their head on the pavement, and they are never the same. So if I make one point for you guys, if you ride bikes, please wear helmets yourselves and educate your friends. And then I talk about things like non-accidental injury, child abuse. I talk about, controversies in, for certain sports, especially tackle football, things like that. I talk about my research because in the next chapter, because it's a very important part of my career. I'm an academic neurosurgeon. I designed clinical trials. I'm proud that I was able to bring an idea that I had from bench to bedside. These are experiments in pigs and then non-human primates. The idea that I had, the one idea I had throughout my career was, for tumors in children in the back of the brain, an area called the posterior fossa, particularly the fourth ventricle between the cerebellum and the brainstem. We treat them with surgery, radiation, and chemo. The radiation is very harmful to the developing nervous system. And for chemotherapy, we have to give such high doses of drugs to bypass the blood-brain barrier that we wreck other organs that have no disease. So I thought to myself a long time ago, why are we not infusing drugs directly in this spot? And nobody had ever done so. So I spent 20 years working on it. I had many failures and some success, and I talk about that journey. This is a patient with a malignant tumor in the back of the brain in the fourth ventricle that you can see. I don't know if you can see my cursor. This is the middle image is an intraoperative image, which shows that the tumor has been resected, leaving that little red carpet on the floor of the brainstem that we leave behind because removing it doesn't confer a survival advantage, but can badly hurt the patient. The post-op MRI looks absolutely clean with no tumor in that space, but I know that I've left a carpet of tumor behind that's visible under a high-powered operating microscope, and then we give chemotherapy infusions. This is in non-human primates. This is talking about the technique I developed to insert a catheter in that space in the brain. This is my first patient. He came from Alabama. He was 19 years old. He's in the book. His name is Jordan. I use his name with his parents' permission. And he had failed every treatment known to man and was told he had about 3 months to live. He had tumor in many places throughout his brain. We put a catheter in the fourth ventricle and started giving infusions, and his tumor started melting away. And it melted away from the spine as well. He wound up living 2 years and a few months. Unfortunately, his tumor ultimately recurred and he died, but he lived a lot longer than he would have without our treatments. Not good enough, obviously. I think the biggest message I would give to students from who are interested in academic medicine. What I thought when I was a student is that I'm not smart enough to do meaningful research. I was a history major in college, and I have never, at any stage in my life, been the smartest person in the room. I wasn't the smartest person in high school, not in any class in college, not in medical school, not as a resident, and not as a faculty member. I was often the hardest working or one of the hardest working. But just being in medicine, just observing things clinically, you can come up with ideas and then learn how to test them. It's very doable, at least it was for me. And it's something I didn't know that I had the talent to do. In the book, I talk not only about my journey with research, I talk about the emotional bond I form with these research patients. And I talk about the emotions that go into being a doctor. There are stereotypes about doctors and particularly surgeons. We're kind of hard-nosed and, we don't have emotions. And, I don't think any of that is true, and it certainly shouldn't be true. This is Jocelyn, who I talk about in the book. She's an adorable little girl who had a recurrent malignant tumor in the fourth ventricle, an ependymoma. She failed multiple surgeries, multiple other treatment options, including radiation several times, chemotherapy options. She has this adorable crooked smile because she has facial weakness on the right side. And I recall, as I talk about in the book, that whenever I would examine her, I would ask her to walk, to just examine her gait. And instead of walking, she would always skip down the hall, and doing more than I asked. And it was so cute watching this little girl skip down the hall. And we become very emotionally attached to our patients, at least I do, and especially attached to the research patients. For a typical surgical patient, we go through surgery and it's a big deal for families and postoperative care and all that. For these research patients, we go through that. Plus, she would come back week after week from San Antonio for my team, myself and or my physician assistants, to give these infusions into the brain. And at the end of all these infusions, you kind of hold your breath. And as the MRI scan images come up, I talk about the emotions that I felt, that I couldn't focus on anything else, watching and waiting as her images slowly came up on my screen, and how devastated I was when I saw that her tumor had recurred, had laughed at the therapy that I had given, which was her last hope. And I had to go and tell her parents that she was going to die of her untreatable disease because there was nothing left to offer her. And I recall that conversation vividly because I absolutely broke down crying, like uncontrollably. Very unprofessional, I thought at the time. Um, Years later, when I discussed it with the family, and I asked them, do you remember that conversation? Of course, they remember the conversation. They'll remember it their whole lives. And do you remember my emotions at the time? And I hope that wasn't inappropriate. What they said was actually, it brought them great comfort because it felt like I was actually in it with them. And it's an important thing to pass along to you guys as well. It's okay to show your emotions when you become a physician. In the last chapter, and I think this is of great interest um, excuse me, to this audience. You guys are young, idealistic. You mentioned interest in global health. I've done a lot of work in global health over the course of my career. When choosing to become a neurosurgeon, I was actually worried. At the time, I was ignorant that I thought it might be hard to do things in neurosurgery compared to other specialties. I had a passion for serving the underserved. I had worked in a homeless shelter in college extensively, and I thought I was going to do primary care until I fell in love with neurosurgery. But I found there's actually many ways to contribute. This is a picture from Guatemala, and this is a typical scene when you go down to one of these countries. Word spreads that there's going to be a neurosurgeon from the United States coming to do X, Y, or Z, and the patients come from all over the place, from different villages, and they're lined up and they're waiting to see you. My focus has primarily been on teaching. This is a kid with a huge head. You would rarely, if ever, see that in the United States, from untreated hydrocephalus, where the fluid that's circulating in the brain doesn't get reabsorbed properly. This is called a myelocystocele, a rare lesion that you would never see in the United States to this extent. It looks like a basketball on this kid's back. It's a closed neural tube defect where the spinal cord ends lower than normal and the central canal of the spinal cord opens up and fills the space with fluid, and it expands and expands. Easy to fix with surgery. We did surgery and this kid should have a completely normal life with a small scar on the back. Um, I focused on most of these trips, particularly as I got more experience, not on just doing surgeries, but on teaching others to do surgeries in their home environment. It's the teach a man to fish concept rather than giving a man to fish and he eats for a day. You teach a man to fish, and or of course a woman too, and they fish for a lifetime. So you teach them, how the neurosurgeons locally, how to do these operations, and then they can save lots of kids. Big focus on education on these trips. So I'm going to lead into, that's the last chapter, and that's the summary of what's in the book. And I hope you find it meaningful, those of you who choose to read it. I'm going to talk about the end of my story because you guys are young in your career, early in your careers, and I've had a curveball thrown at me, and maybe it'll be instructive at some point to have heard this because curveballs may be thrown at you or your family in different points. A number of months ago, I unfortunately started developing a tremor of my right hand, and it was very subtle at first, not affecting my surgical procedures because it occurred only at rest. And when my hands were in motion, the tremor goes away. And so, even under a high powered operating microscope, I was taking out brain tumors and doing great. But my wife noticed it at first, and then I noticed it. And then I noticed I wasn't swinging my right arm as much as I left. This is a nuclear medicine study. This is my study. I'm the patient here, and it shows a decrease in uptake of dopamine in the left side of the brain in the basal ganglia, corresponding to my right hand, which is confirming the diagnosis of Parkinson's disease. So I've been diagnosed with Parkinson's disease, something I never expected, obviously, at the age of 53. And after much reflection, I saw 3 neurologists, and it was very difficult to figure out what to do because I'm so passionate about my career, as I think you can probably tell from this talk. Um, but I decided that I never wanted to be someone who stuck around too long, like, certain professional athletes who are amazing in their prime and then stick around too long. There are surgeons who do that too, who stick around well into their 70s and they're not as good with their hands or their minds as they were in their prime. I never wanted to be one of those, but I never thought I would end my career at 53. But I never wanted to leave a doubt as to whether I would hurt a child or anything. And it's not a good look to have a neurosurgeon with a tremor. So I retired effective June 30th, effective just over a week ago from pediatric neurosurgery practice. And then the question was what to do. Um, and I'm taking kind of a unique career path that few, if any, have taken. After much thought, I thought about continuing in teaching and research in some capacity, but for various reasons, I decided to have a completely second career that's focused on childhood poverty. I haven't decided exactly what to do, but I'm enrolled at the University of Houston to get a master's in social work um, starting in the fall. And then I'm going to figure out something great and meaningful to do because I've seen so many social ills in the hospital and I can still be there for families and help in some way. So that is my story. That is the book. And I think I talked a little longer than I intended, so I apologize for that. But I'll stay as long as you want me to answer questions from any of you guys.
Wow. Well, this has been extremely insightful. So I just first of all wanted to issue a huge thanks, Dr. Sandberg. I mean, this is, I learned so much, and I was actually already at one of your other events a few months back, and I still learned more. So really appreciate that. We will open up for audience questions in just a minute, but I just wanted to start by initially asking you something which I was kind of noticing while you were walking through your various slides, which is that it seems as if you had a very deliberate structure in so far as how you ordered the different events in the overall book. It isn't as if it inherently or solely followed a true chronological order, but rather it seems as if you move between different goals in the sense of you open up with one of your former patients that, as you were saying, still haunts you, and then you move on, speaking more about your own academic journey, and then kind of eventually end up on the modern era. So with all of that, I just wanted to ask, how did you approach the order, and do you think that was something that you knew before you even started writing, or rather is it that you basically looked afterwards and thought about what order might be most effective to actually narrate all of these different events?
It's a great question. So I started by I thought the story of Marcella before she died, it's still a beautiful story, but I thought the story of Marcella, the girl from Honduras, was such a beautiful story that I wanted to just write it down in its complete detail. So I wrote um, about 15, 20 pages just just about her story. And, I showed it to a few family members and a few friends. I didn't really do anything with it beyond that. And then when I decided I was going to write a book, the next chapter I wrote was the chapter one about Garrett. I didn't know it was going to be the first chapter, but I thought his story was really illustrating regarding the uncertainty we face as neurosurgeons that the general public and students really wouldn't be aware of because you don't see that. You just see us making split-second decisions and you don't feel or hear the uncertainty in our minds. So I wrote that chapter next. And then I started thinking about chapters that I wanted to write, things that I wanted to say. And I have a lot to say about complications. I have a lot to say about delivering bad news. I knew those would be chapters. I knew I wanted to talk about my research. I knew that all of it required some context. So I would write a chapter about, my training and background. I knew I wanted to write about what a day in my life was like. So they just became chapters. And then I decided on the order after most of the chapters were written. Um, I decided to start with the Garrett story, just kind of as a hook for an interest in neurosurgery, and then go to my background and training. And then the order of the subsequent chapters, I don't know if it was that important.
Excellent. No, I really appreciate that in-depth insight. With all of that, if any of our audience members want to raise their hands, we'll definitely start to call on um, all of you. So I see that Justin has his hand raised. Feel free to go ahead, Justin.
Firstly, thanks again, Dr. Sandberg, for your amazing presentation. In this second phase of your career, if you will, have you considered branching off into health policy or public health in terms of addressing childhood poverty alongside your master's?
No, I thought about getting a master's in public health, and I decided I wanted to do social work purely because, I'm someone who gives my whole self. And if I wanted to be in medicine, what I really want to do is be a pediatric neurosurgeon, which I love. But it's hard to be a pediatric neurosurgeon without the neurosurgery part. And so I thought what would bring me the most happiness was to do something totally different, like working in a homeless shelter or working in the foster care system. I've seen so many foster care kids have so many problems, or kids who are victims of child abuse, non-accidental injury, or work with kids in the prison system. I want to do something with children, likely non-medical related, and that's why I decided to pursue the social work route.
Excellent.
I
Appreciate
may
it.
change my mind. I reserve the right to change my mind.
And I'll actually just ask a brief follow-up, which is I think many of us at SEAL and various institutions and paths, all of us are very kind of interested in broader system level issues, as Justin was um briefly speaking about. I was hoping to ask you about, based on all of the various patients that you've seen, if there's kind of one that specifically stands out or is a good example of kind of how the broader social ills in our nation and our world actually affect or, may even hamper slash impede the ability of surgeons and other physicians to effectively do their work.
Yeah, I mean, I think there are so many. I can't think of one specific patient who kind of illustrates all points. One of the things that I see is a lot of violence in teenagers, right? So, kids who are in the gun and knife club, who are in gangs, if you get to know them and you know their stories, you kind of have a little more sympathy for them. There's a reason that I'm a pediatric neurosurgeon and not a gang member. I was born into a loving household with two parents who gave me every opportunity to succeed in school and loved me and nurtured me, etc. Most of the kids who are in those situations, they've done horrible things, but their background, it doesn't apologize for it or explain it completely, but you kind of understand a little more. Non-accidental injury is a product of uneducated parents. We see a lot of babies who are shaken or abused, some of whom die, and it's such a tragedy. One day, some of you will have babies of your own. Maybe some of you on this call already do. And you'll see that it's actually quite frustrating when your baby is crying in the middle of the night. It's 2 a.m, you're exhausted. You've been up all night the night before with the baby, and you tried everything, feeding them, burping them, singing to them, and you can't get the baby to stop crying. I experienced that with my own babies. And then I was like, now I understand why an uneducated parent at this moment might shake this baby, right? And so, um, you know, see a lot of different tragedies that I could speak about. Um, Kids not wearing helmets is a big one because it's so preventable. Garrett's case, while illustrative, didn't have to happen. If he was wearing a helmet, he never would have had to go through brain surgery. So lots I could talk about. I could talk on that topic for a long time.
Great, thank you so much. I personally am incredibly interested on the variety of different roles you've taken on in your career, from like researching neurosurgical techniques versus like going and working in Guatemala and Honduras and all these other low and middle income countries. Like my question is like, what is your calculus for approaching change in the first place? Like you started off as like a neurosurgeon, which is like a very specific sort of specialty that works on a very subset number of indications and diseases, and then eventually you brought into global health and things like that. Like how do you approach change in that capacity, and how is that definition of change like altered or went through a transformation as you approached other things in your career? That makes sense.
Yeah, good question. Um, Hard to say how I approach change in a general way. What I can tell you is, well, let's first talk about global health. So global health has always been a passion of mine. My father took me on 3 medical missions when I was in high school and college. He was an ophthalmologist, as I mentioned, and I saw him doing surgery on patients who had cataracts that were so thick that the patients were blind, essentially. And he would take out the cataracts and the patients could see. You would never see that in this country because there's a lot of cataract surgeons and a lot of cataract surgery that's done very early, which is appropriate. In these countries, there were patients that are blind from cataracts, and I was like, wow, my dad is making these blind people see, and this is amazing, and I want to do something like this. So I always had in the back of my mind that I wanted to do something like that, and I was lucky enough to just come across the opportunity and jump on it. When I was a second-year resident, there was a neurosurgeon named Neil Feldstein, who was at Columbia University, who came to my program, which was Cornell across town in New York City, and gave a lecture on these trips he had gone on to Guatemala. And I literally begged him, I would not take no for an answer. I was like, this is a dream of mine. Like, can you please take me if you go on another one of these trips? And I literally begged him, and I would not leave him alone until he said yes. And he took me on 2 of these trips, and then other opportunities arose. So it's been a hugely important part of my career. Um, as far as the research is concerned, I quickly realized that I was a neurosurgery resident that for pediatric neurosurgery specifically, most of the good pediatric neurosurgical cases come to academic institutions, not exclusively, but in many cities, academic institutions, if your child has a, horrible thing like a brain tumor and you live in Palo Alto, you're going to wind up taking your patient, your child to Stanford, not the local neurosurgeon, where there's going to be a pediatric neurosurgeon and a whole team of people who deal with these things. And I became interested in the topic of brain tumors, and I saw the inadequacies in treatment. And luckily, I came up with an idea that was something that was worth studying. Um, so I don't know how to answer the question exactly regarding how I approached change, but I certainly seized opportunities that came my way, and I certainly went after them with great passion.
Excellent. I see that Mahir has his hand raised, so feel free to ask your question.
Hello, Dr. Sandberg. From like looking back from your experiences during medical school years, like what are the moments of mentorship or research that sort of awakened your passion for pediatric neurosurgery, and like how did your early experiences shape your approach towards caring for children and their families in such vulnerable circumstances?
Yeah, it was a long evolution. I didn't actually decide to become a pediatric neurosurgeon until I decided to become a neurosurgeon first. So everyone has their own path. As I talk about in the book, There are some people who decide they want to become a neurosurgeon when they come out of the womb. I don't know how they figure it out, but they've, since childhood, like, I'm going to be a brain surgeon when I grow up. I was not one of them. My path was first deciding I wanted to be a doctor. The main reason I wanted to be a doctor was I saw what my dad did on these medical missions, and I was like, this is an amazing way to help people. He has a great life. He loves his job, and I love my dad, so I wanted to be like him, as many children aspire to be like their parents. So that was how I decided to become a doctor. Um, I became interested in the homeless population just because of some circumstances. I grew up in Miami in a sheltered environment. When I went to college in Boston, I was so naive and I was shocked to see people sleeping in the streets. And, why is that their best option? And I started researching that and looking into it and helping the homeless, and became a director of a homeless shelter. And so I wanted to incorporate some of that into my career. And it's interesting that now I'm going to become a social worker and work with that population again, likely. So that has roots. Um, but I knew I wanted to be a doctor. I went to medical school with an open mind about what kind of doctor. And then in the rotations, a few key moments. One was my emergency medicine rotation. In emergency medicine, you see how patients are triaged. And I just found the surgical patients to be very interesting. Another was my general surgery rotation, seeing the conversations that a surgeon has with his or her patients, um, very direct conversations about a specific scary problem and how to solve it, or that it can't be solved. I like those interactions. And I thought I could do a good job at those. And then once I became a neurosurgeon, there's nothing more compelling to me than a child with a brain tumor. I became interested in pediatric problems. Um, I didn't like certain aspects of adult neurosurgery, particularly adult back pain. That wasn't for me for various reasons. And so that's my path.
Excellent. I see that we have a question in the Zoom chat, which is, asking about any advice that you may have, specifically for medical students and or residents who are in their earlier stages, who are still trying to understand or grapple with any of the complications that they will inevitably have, and kind of more, also how maybe you have handled any of those issues as you have operated over the
Yeah.
years.
The good thing is that, medical students and residents, while they may participate in cases in some way and contribute to complications, particularly residents, the ultimate responsibility lies with the attending neurosurgeon or the attending surgeon or the boss, if it's in a medical service, the attending, medical doctor. And so you're not ultimately going to bear the responsibility for those complications. What I would encourage is any opportunity you have to attend morbidity and mortality conference, you attend, because that's an incredible learning experience, because you see, as I talk about in the book, what those conferences are like. You take the worst day of your life and show that worst day of your life in front of 50 to 100 people. Your boss is in the room, there are students in the room, there's people you don't know in the room, and your worst day of your life is shared with great detail and video and pictures and discussion about what you should have done differently, with everybody kind of pointing the finger at you. And it's hard. It's also incredibly important. And I've learned more from sitting in that room over the years, learning about other people's complications and my own complications, than almost anything else.
Excellent. I see that Ohm has his hand raised. Feel free to go ahead.
Hi, Dr. Sandberg. Once again, thank you for sharing your story. I just had a question about your work and how, like, what do you believe your work has taught you in terms of resilience in not only yourself, but also seeing resilience in children and families?
Yeah, kids are amazing and their families are amazing. I've seen families face the most horrible circumstances with bravery that I don't know that I would have. In fact, now that I go through my own struggle, I am lifted up by the families who have faced worse circumstances than my own. You know, I've told parents that their children have died or are going to die. I don't have a fatal disease. I have a progressive neurodegenerative disease, but I expect to live a normal lifespan, I hope. God willing, I'll be spared the worst of Parkinson's, and not to minimize it, because there's a lot of bad things that can happen. But I'm definitely lifted up by the courage of my patients. Um, and as far as resilience is concerned, You know, it's hard. My career was hard, but it was so meaningful and so rewarding. Luckily, the good outcomes outweighed the bad, and that's why, I'm able to swallow the bad. But I talk in the book about the emotional process that I've gone through. Excuse me a second. Um, and now I'm trying to have resilience. My wife phrased it very, very well. Give me a second. I'm just gonna put my phone on silent. In terms of my own diagnosis now, one story that could be written about me one day is that I was a pediatric neurosurgeon. I saved a bunch of kids' lives, and that would be a good story. But even better is, as a legacy for my children, is that I did that, and then life threw me a curveball, as it will throw all of us. And I did something else that's meaningful. So I'm moving towards that fulfillment.
Thank you.
Thank you. I just have one last question, which is kind of more specific on the global health end of things. So you had spoken about, your work over the years helping to build and support neurosurgical workforce in other nations. And I was interested to ask, as of now at least, like, in this year, where do you feel we are from a neurosurgical landscape as insofar as low and middle income countries go? And what do you think is next, specifically when we look at how much of the existing global health, funding with entities like USAID and others has been substantially stripped or wiped away? How do you see us being able to sufficiently invest in these areas in the years and the decades ahead?
Yeah. The USAID stuff is devastating. I'll stay away from politics, but I'm certainly not in favor of those decisions that are being made. Um, the answer, as far as neurosurgical care in low and middle income countries, is very country dependent. There are some places, in sub-Saharan Africa where there are no neurosurgeons, or one or two, for populations that are in the millions, and there's basically no reasonable care. There are others, sites in sub-Saharan Africa, which is the poorest area of the world, where there's been incredible progress, where there are residency programs now that have sprouted up that are partnered with residency programs in the United States. A great example of that is Duke University has paired with a program in Uganda, and they are training neurosurgeons in Uganda to perform modern neurosurgery. They're equipping them with modern equipment with millions of dollars of donations, and it's incredible. So it's very site by site dependent. I used to go to Haiti. I've been there about 10 times. Haiti's dear to my heart because I grew up in Miami, and Haiti's a very short plane flight from Miami. It's so close. And yet the poverty there rivals that of East Africa. I can't go there anymore, even if I was still practicing as a neurosurgeon, because it's simply unsafe. It's basically run by gangs, and it's just not safe to be in the capital, Port-au-Prince, where the hospitals are. And the hospital I used to work at burned down. It was burned down by gangs. And so, very place by place dependent. There are some places that there's a lot of hope, and other places where there's continued despair.
Awesome. So I think we're just approaching time here. And with that, I really want to thank you, Dr. Sandberg, for your inspiring story and the time that you gave us this evening. We really appreciate it. And I'm sure you've inspired a lot of other future medical leaders in this call. So thank you so much.
I wish all of you the best of luck, and it's my pleasure to join you. Thank you again for the invitation.
Yeah, and we will also be, after this is over, emailing out the link for his book as well. So we hope that many of you end up reading it. It's an excellent book.
I
Thank
see all these clappings and hearts floating across the screen. Thank you to all of you who are sending those kind messages.
Absolutely. Okay, excellent. Well, thanks again. Means a lot.
It's a
I'm
pleasure.
able
Good
to
luck to all of
honor
you
Dr.
guys.
Sandberg.
You're at the beginning of a great journey. Thank you.
Thank you.
Take care. Bye-bye.